Sorry about that, I must have accidentally clicked the button. What I want to talk to today is really about how a primary healthcare organisation used both data and evidence to change practice. So it's a bit of a story. There's a lot to get through that I'd like to share with you, really just to trigger thoughts. So I'll dive right in and try to do it within my allotted 20 minutes. So Larry Green made this statement well over a decade ago, but I think this is very much as true today as when he first made the statement. We know that much of the evidence on which we base our practice and up until fairly recently, the data wasn't really suitable for the job we were trying to do in terms of evidence-based practice in primary care. There's two questions about how to use data in quality improvement, two approaches. The first is using data as an external control, which and Barbara Staffen and I wrote over a decade ago around this. The effects of this tend to be demotivating and undermining of the respect for patient autonomy. Using data to improve care quality as a guideline or target adherence is a simplistic approach, and I'll explain why in a minute. And it can drive poor care rather than better care, can undermine good care, and tends to drive a lower touch approach in primary care. So the other alternative is a kind of a bottom-up approach, so something that emerges from within primary care, which is, I think, what you're trying to do with your organisation. So this one approach in the past has been to take guidelines and then measure adherence in a kind of an audit, top-down audit and feedback approach. We know that there's been various approaches tried with the use of data to improve quality, and audit and feedback can have a small, but it's pretty modest in terms of its effect and effectiveness. And most of the evidence around changing behaviour favours complex interventions that look beyond just data, look at the context. On the back of this adherence to guidelines, kind of a top-down approach, quality metrics and pay-for-performance models also sprang up. And these were related to really accountability and market theory, and it tended to centre primary care around measurement and a bit of a reductionist attitude, aimed at health improvements and professional pride, but there's a lot of evidence around pay for performance, mostly from the US and the UK, that found that it in fact had the opposite effect, that it triggered professional passivity, a learned helplessness, a cynicism in an industry of compliance, coding and electronic support. So what I'm going to do just today is to give you, it's not necessarily the way to do things, it's really just a case example of a bottom-up approach to using data to change practice, to try and trigger some thoughts. So this is based in Canterbury, in New Zealand, and there's only one thing you need to know about New Zealand is the area that's Canterbury and the rest of New Zealand, which is not Canterbury. It's a very parochial part of the country. And what I'm going to talk about is an approach that has been sustained. So this is the very first research project that I ever did, and the first program I was involved in developing. And this program remains in place fairly unchanged, a bit more sophisticated, but 30 years later, so it's been enduring. The approach to data in that program is a feed forward for quality improvement topic area selection. So there's no point in doing quality improvement if there's not really a gap between where you'd like to be and where you are. That's just wasteful of time and resources. The approach to the data was very much grassroots generated, so it really emerged from curiosity about the gaps in care and where these things might be improved, rather than the top-down approach that I've talked about. And it looked at the data in different ways. It looked at utilisation over time, looking for changes. Where are things looking different and why? Monitoring against changes in evidence that emerged, and to identify apparent divergences from best practice to try and understand what was behind them. Sometimes divergence means that practice is poor. Sometimes it can mean that there's appropriate variation given the context of multi-morbidity in which you're applying the evidence. And sometimes it in fact means that practice is ahead of the evidence in terms of what actually works best for patients. We used a clinical reference group that interpreted that data and sought further data to answer questions. So very much an iterative process of looking at these data streams and then asking further questions to refine and understand what was going on. And then, as well as that, the approach to data was to use audit and feedback for self-reflection on the areas that were chosen for quality improvement, and that's what I'm going to talk about in more detail. And also as follow-up data for that program feedback to see whether the quality improvement initiative, just the PDSA cycle really, did it achieve what was hoped for. And I'll give you some examples of that as well. So the way that this model of QI works, and it remains fairly constant, as I said, over the decades to this day. But groups of 10 to 15 maximum family doctors were led by a peer, a respected opinion leader, and had regular case-based discussions once a month for about an hour and a half. And those discussions were informed by an evidence-informed literature search around the topic that had been identified for QI, some cases for discussion around the key issues that had been identified in the data, and then integrating that data both to assess the trends and inform the topic, but also for individual self-reflection related to the topic. So it was very much a how am I as an individual doing compared to the peers in my group, and how is our broader network doing? And then, as I said, assessing the effect. Who was involved in this process? So originally it was a very small team, education team, and GPs who are family doctors that have qualified and that would done specialist training. So it's different from a GP in Canada. And then with time, in fact, this program was joined by nurses, primary care pharmacists, and enough funding was secured to incorporate formal analysts into that, and relevant secondary care advisors as appropriate, depending on the domain area. The group process is that the GPs have all done some pre-reading of the evidence, short, but just some things to set the context. And then the small group leads a discussion based on the cases in the slides, but it's not didactic, it's very much a case-focused discussion informed by evidence and data. The group leader will bring out any key points if they haven't come out in that discussion towards the end of the session. And very much key in that, and I'll talk in a minute about why, is what we used to call jokingly the slide of shame. And these groups were a very safe environment. It was Charterhouse rules, nothing was shared outside the group, but we would see with our name on it our individual data compared to everybody else's with their names on as well. And that really provided, there was a bit of diffidence about that approach to start with, but actually it was critical in I think, in engendering the behaviour change that we were seeking, and understanding the why of, why we would see certain things. For example, we saw with inhaled corticosteroids, when people switched to fluticasone, we could see that somebody was a real outlier, and in talking to them about, why is it different for you, they'd made the dose or the potency adjustment correction in the wrong direction. So they doubled the dose instead of halving. And it always kept time, the group process, which is pretty key as well. And this is the assumption, that it assumes that doctors will practice rationally and well if they're given the tools and support they need. So independent evidence that's relevant to primary care, feedback of their data, and the opportunity to discuss this with peers and appropriate incentives. So the theoretical basis for that, and it's really important to when you're thinking about quality improvement, I think, and behaviour change, to not just think, well, we think this is a good idea, but to think, why might it work? Are there reasons why this might work to change practice? And we very much based this approach on the weighted evidence at the time for what affected behaviour change and that was relevant to kind of primary care practice. So there are three mechanisms by which behaviour change occurs, and we sought to really engage with all of those. One was the accumulation of the weighted evidence, so that evidence literature searching piece. The other is a critical or challenging event, so it can be a disaster with a patient or a locum with a different approach. And in this case, we use that slide of shame as a kind of could be a challenging event of why, oh, I'm different to everybody else, why is that? And then there's a continuity piece, so the family doc seeking to an answer to a solution, i.e. a background willingness to change, to attend these meetings to improve practice, or an openness to improving practice. As with all things, it's really important to show that you did what you thought you were going to do. And so we actually implemented this initially as a pilot controlled trial with four topic areas and some pilot small groups. And we evaluated the extent to which the program actually reached the intended goals of changing practice. We also looked at the time to extinction of any effect on what we saw in behaviour, and this is what we saw. So we identified 8 key messages and outcome indicators, and we chose prescribing indicators because really they were the easiest to get data on, and to be certain that we had all of the data that we needed. But the rationale behind that was if we could see change in what we could measure, that we could assume change in the unmeasurable as well, because it's not just what, as we all know around the table here, it's not just what you can measure that's important. So it would provide proof of concept for those things that were unmeasurable as well. We extracted data from the National Dispensing Database, which is complete in New Zealand, for the intervention in 2 control groups at 3 monthly intervals for 2 years after the intervention around each topic area. And this is what we found. I don't want you to read the table. I just want you to see really what you see in red is a statistically significant effect. And I just want you to look at this to see for the different messages what the time to it. You can see visually what the time to extinction is of those messages. You can read the paper if you want to look at it in full detail. But this, in summary, what you saw there visually was that there's conclusive support for the effectiveness in actually changing behaviour. So the outcome that matters, not just change in knowledge, but change in behaviour. Over a variety of outcome measures, the effect size was between 7 and 40%, and that change is statistically significant over 9 to 24 months. After the significance disappeared, you could still see the effect in the same direction, but you could see that there was a sort of a dilution effect. And so that's a really useful thing to understand when to circle back to things again. You know, how often do you circle back to particular areas and look at them again? And it's you see change more quickly in, for example, prescribing indicators that are more likely to change quickly. So antibiotic prescription, because it's sort of in the moment, you could see a much sharper change. And then obviously chronic prescribed medications take a while because the patient has to re-present and have a discussion, those kind of things. So we saw those kinds of effects. But even a small change, so the 7% change, was a purely cost message around metered dose inhalers are a lot less expensive and no better than the breath activated devices for the majority of patients, and they cost a lot more. And so that small 10% effect over the course of the study made a difference in cost to the drug's budget of hundreds of thousands of dollars. So small changes can be important as well. So what this does is it provides proof of concept. And what that means is that you don't have to reprove the effectiveness of your model every time you do it. If you prove that the mechanism works, and whatever mechanism that you choose, once you've proved that the concept works, then you can put in anything, measurable or not, that's important in relation to quality improvement. And I'm just going to show you some examples then you can just do before and after and feel confident that most of what you're seeing is real rather than just sort of variation with time. As I said, it's continued now for over 20 years, nearly 30 now, and really this evidence of proof of concept has also been very helpful in sustainability as you know, political agendas for primary care change and for data change. I think it's very important to have that solid evidence to say, well, we know what we do works. So if you wanted to change this, you have to show me that something that you're suggesting is better, or at least as good as. It's voluntary but irresistible, so 70 to 85% attendance average per topic. And it really gives people, they say, the confidence to feel like they're ahead of the game, and that what they're doing in their practice is evidence-based and is sort of up to date and serving in the best service of patients. And as I said, it's now expanded to other groups. Let me show you some sort of specific areas since that initial study where we used the data. One is, and this was an example of where we noticed a change in just our regular monitoring of drug classes and things, and thought, holy moly, what's going on there? And this was patients under 1 who were being dispensed a PPI. And this rose to, you can see, where nearly 15% of infants were being given a PPI, which is kind of crazy levels. And there was a big marketing campaign going on around reflux at the time and PPI and the dangers to infants if it was untreated. And you can see here that Canterbury, because the marketing had been very intense in Canterbury was at the top end nationally of use of PPIs as a proportion of sort of live births in infants under 1. So we implemented the educational messages in the package, and this is the kind of feedback that that each individual, I blanked out the names, but each individual would get on the proportion of their live births of the patients in their practice who were prescribed omeprazole. And you can see here that it shows the variation of the range and enables people to see, oh, gosh, I'm even an outlier within the group, but also I'm an outlier compared to the evidence. And this is what effect that particular QI cycle had. You can see that we've now dropped to being probably in the lower proportion of use nationally, and that was a 10% change. So that was a sort of dramatic illustration of the effectiveness ongoing. Some of the key things, so I've reflected on a few things that I think might be useful for our discussions. The bottom-up clinician-led data governance was essential for effective use, for trust, and for the ability to ask the right questions of the data. And so I'm going to give you an example of that. We noticed in one of our other just routine monitoring, we noticed this change in quetiapine dispensing. And the first assumption was that this was being driven in what we know is a concern globally, which is the use of antipsychotics in older adults, and particularly in long-term care. But in fact, in asking questions of the data, what we found, we said, okay, let's just see if that's the case. And what we found was that actually the growth was larger, the change was larger in that mid-age band. So we thought, okay, what's going on here? And then it became apparent that there was marketing of quetiapine, accidentally in some cases by psychiatrists, in talking about quetiapine as a safer, it was perceived as a safer hypnotic for insomnia, and that was the way it's being used. It was actually being used in small doses as a hypnotic, mostly in middle-aged people, driving that growth. So we're able to target the QI cycle to that by asking the right questions of the data. The other thing that we found is somebody said, okay, so what other drugs are associated with this? And what we found was that that in that mid-age group, that the co-prescription of antidepressants and quetiapine as a sleep aid was high, and in particular for venlafaxine. And so what we surmised was that the agitation or poor sleep, that we know that SSRIs give poorer sleep, and that the quetiapine was being used to treat that. So what we were seeing, in fact, was a prescribing cascade. Data can also be used for myth-busting, and we know that this is an example of a myth, which is that if you allow family docs open access to expensive investigations or pathways, that they will overload them and it will be expensive and there'll be a budget blowout. So like my own province, Ontario now, GPs weren't allowed to access either D-dimer tests or direct ultrasounds for DVT diagnosis. And we felt that that if a pathway was opened, that GPs wouldn't overuse this, and so we ran a pilot to try and test this, and we looked at the data. And what you can see here is when because these patients were going to the emergency department instead for their D-dimers and ultrasound, and it was not something that you needed to go to an emergency department to do. And so you can see here the effect of introducing that pathway on the emergency department ultrasound use, so it had the effect that we hoped. And then we looked at the question, okay, did that result in an overuse in primary care? And what we found was this, that the positivity rate for ultrasounds in the emergency department, when they were ordered as they felt were indicated, the positivity rate was 13%. In the ED after the project, it was 11%. And you can see the referrals to the GP pathway achieved exactly the same positivity rate. So there was no evidence for overuse or misuse. So that was a way of busting that myth of if you allow access to, wider access to GPs, that they're somehow going to be irresponsible. Another thing that I think is important to think about when you're looking at data, often we use data to measure what we do, and it's all about doing. And I think it's really important to look at this paradigm of cautionary prevention, which is looking at overuse and understanding when not doing something might be the best possible approach. And I'll just give you an example of that. So lab test over ordering is one, and we had a topic in 2003 around wise use of laboratory tests, and there are a range of laboratory tests, everything from when you should order an MSU, which costs $20 per patient, is it going to change your practice or not, to the kinds of liver function tests and when to order them or not. And you can see here, this blue line, there was a general increase across across the nation, and these lines represent different regions, and this blue line here represents Pegasus Health. So you can see a sustained change in that. So in thinking about areas for QI, I think it's really important to think about those choosing wisely, overuse those kinds of things as well. Testing the system in unexpected circumstances. So in 2010, 2011, the city was subject to two devastating earthquakes and tens of thousands of significant aftershocks, which destroyed the central city and the infrastructure, but also had a bit like the pandemic, really, although in a more acute way, substantial mental health implications for the population who are having aftershock adrenaline rushes every day and feeling that psychological impact, fatigue, and ongoing sort of anxiety and fear. So one of the things that we were concerned about was that the kind of symptoms of a normal response to an abnormal situation would be misframed as being a mental illness, given a label and medicated, whereas a different approach was needed. And so we put out very quickly a bulletin we couldn't do a topic because this bulletin was put out using getting the communication systems up and running on a generator. Many practices were destroyed, so the usual small group meeting format wasn't possible, but these bulletins always accompanied small group meetings. So we used a familiar format and gave people strategies for managing the stress, we call them stress symptoms, and gave a strong message that, particularly in the first 3 months, that this shouldn't be framed as PTSD and that SSRI antidepressants weren't an appropriate response, but that short-term benzodiazepines could be used if sleep was severely disrupted, just for a few days to try and get back into normal sleep pattern. And then we used the data to see was this effective, and you can see here that we managed to flatline antidepressants. You'll see that small rise in anxiolytics around the time of the earthquakes, but you see then that it dropped back, so it was short-term prescription only. So again, even in disaster, you can still use data to understand whether what you're doing is changing practice. And then again, another example of how we were able to use the data. This was about antibiotic resistance and using antibiotics wisely. So this is very, very early on. In 2000, there started to be a push from the pharmaceutical companies to move prescribing for UTIs to the broader spectrum fluoroquinolones, and using this kind of laboratory data showing that trimestoprim, which was the first-line antibiotic, the resistance rate was 19%. We had a sense that that wasn't what we were seeing in practice, and so we used the data, laboratory data and the positivity to show that, in fact, that wasn't the case. When we got, this is more of an intervention study, and so we got people to send samples for a period of time on all patients presenting with dysuria frequency, flag them as such, and we found that that this figure had been skewed by people only sending samples for complicated UTIs and for representing all E. coli, not just urinary tract infections. And so we found that the true resistance rate was well less than 10%, so well below threshold for changing, and this enabled the line and the guidance on first-line antibiotics to remain at the older antibiotics for more than a decade after this. Just some other things to think about, which I've sort of alluded to. It's very important in thinking about data to think about how it relates to our patients, and these are our normal patients. And that top-down approach has tended to be sort of more condition-specific, which is appropriate and useful, but I think it's important to remember the broad context of primary care patients, because if we simply use an audit, feedback and adherence kind of approach, this will, and those of you familiar with me will have seen this many times before, but if you take the average 5 diseases that a patient with chronic disease or multimorbidity has, the average over 70-year-old, and apply the guidelines for each one, this is what will happen if you're the good doctor, the guideline adherent doctor, is that while it might look measurably better care, that for this particular individual, and it doesn't matter which conditions you choose, the outcome is always the same, but that care will be meaningfully worse for that individual patient, and leaving the practitioner. I like this image. So this is an image for what I'm trying to describe, is that in being too reductionist and using data, what we can do is we can transform the music of a patient's life and the way their chronic diseases interact. By deconstructing that, we can lose a sense of that music of their life, and also lose the ability to understand how care will best enhance it. And it also creates for us as practitioners a sense of moral distress when we're faced with a situation of, do I provide measurably good care, but I know that actually that's not what this patient in front of me needs. It's going to be measurably worse for them, and it will impose on them a burden that they just can't cope with or manage. So I think those are really important things to measure as we sort of understand and decide how to use and interpret the data. Data can also expose system issues, and this is an example of something we've done recently in McMaster, because I've started a similar practice-based network there. We're not at the maturity level yet of BC or of the network in Christchurch, but we looked at drugs that might be contributing to polypharmacy, and these were drugs that were supposed to be prescribed for an intermediate term, so longer than an antibiotic, but are never intended to be a life sentence. So they're usually intended to be sort of 12 weeks to perhaps a year's prescription. And what we found here, that if you started on one of these classes of drugs, so we chose a psychological, a physical, and a risk factor drug, that in these two instances, if you get started on one of these drugs, then in nearly half of cases, you're still likely to be on them well beyond the usual duration of prescribing. And it wasn't just a little bit of slippage, the median duration was 5 years. And so the answer to that is not people pulling a list of people on these drugs. This is just an illustration of a system problem that needs addressing in our QI. We've got great systems for starting drugs. We don't have a systematic approach for flagging the end of a course or for systematically stopping drugs. It's also, I think, important, I know that you all know this as well, but to remember that the map of data is not necessarily the territory of practice. And this is a nice screen grab from Google Earth. So it shows how just looking at one source of data can fail to render a complete picture. You know, there is no nighttime or clouds on Google's Earth. And I think the same is true of the data that we get from electronic records. There's nothing there yet about what matters to the patient, what their priorities are, their experience of their illness and their treatments are, and what matters to them. And I think, you know, I always think of this visual image. It's a bit like looking at these parts of a bridge. For the bridge to truly be a bridge, you need these to understand these integrating parts, which partly are around the patient, but also around, and this is something I've thought a lot about in the last few years, about how do we use the data to understand the key aspects of primary care that we know are the pieces or the key domains in which it achieves better population health outcomes. We know that the evidence is really strong that the better primary care is, the better population health outcomes are, the lower morbidity and mortality are, and it doesn't matter which way you measure it, that the same is true. And there's no such evidence for any other part of the health system. So how do we make that visible in data as well? And I think it's thinking about how do we measure both in specific topic areas, if it's possible, but also in our bigger picture. You know, you might want to do a HDC, you know, annual report on things over time. You know, how do we measure person-focused care over time, continuity and integration, access, comprehensiveness, minimally disruptive medicine, the art of not doing, and the reduction of excess care. So I think as well as very specific measures, we can really achieve a lot if we keep and think about measures of these kinds of things as well. So I'm just going to finish up now. Those are just two examples, really. Just going to finish up now by saying, you know, I think these are the questions that we're answering with these kinds of efforts, and what we're trying to do, what you're trying to do here is what we're doing worthwhile for us and patients? Are we using public money effectively? Is it a good experience for everybody involved? And other claims that we're making about quality and effectiveness and innovation, are they actually true? So I'm just going to stop there. I hope it's provoked some food for thought. But it's not the only way. It's just kind of things to prompt thinking, and I'm happy to answer any questions.
Great, thank you so much, Dee. That was very fascinating. Lots of good evidence for a very solid program that's been built there. So yeah, let's actually open up the floor then for some questions from the folks here.
I'm trying to stop screen sharing. I'm not sure that I have. Am I still screen sharing?
You are, yeah.
I am. Okay, I'm just trying to get to my full view again.
So Dee, I am so impressed with the continuity of the small groups supporting each other for decades through this quality improvement framework. How does that bode well for sustainability in primary care in Canterbury? I mean, we're facing a major crisis right now.
Yes. And in Ontario, and I think you know what happens in terms of QI and data and things is pretty critical right now in the Canadian primary care. And I hope to illustrate the ways in which you can make visible the importance of primary care and those other key aspects of primary care. And I think that the education program has really been critical in the sustainability of primary care, because the whole organisation has been very deliberately politically agnostic, and I think that's really key. That you decide what your mission is for the 10 to 20 years, and work in a really excellent way with whatever policy organisations and infrastructure and things are in power. But as we all know, you know, things change, funding centralises, decentralises, governments change, that kind of thing. So I think that sort of eye on the prize, what matters to us in our vision for primary care and quality in primary care, I think is really important. And I certainly think the evidence we were able to do in that first research project was really helpful in sustaining that through that, be able to say, well, we've got a really, really good evidence to show that what we do works to improve QI. You show us that your good idea, which is not necessarily based on any evidence, is going to do any better than this, and we'd be happy to test it out, kind of thing. So I think that has been, and also I think it gives credibility as well, to primary care. And I think in most countries around the world, primary care emerges into the health system as being regarded as a bit of a kind of a Cinderella, and so I think this gives some credibility and weight as well, that we're putting our money where our mouth is. I think also a key part of that sustainability is being prepared to say when you're wrong, when the data doesn't support what you think it says, and say, well, and also to sacrifice your good ideas, when you have an initiative and it doesn't work, not to say more research is needed, but to say, actually, it doesn't work, leave it, move on. Yeah. Also, I'd say that that education program, you can see the attendance rate, it became a really important vehicle for sort of primary care policy and cohesiveness. So there'll be a director's slot for 5 or 10 minutes at the beginning of everyone's, where any topical issues could be brought to the group, and you could get true feedback from all of the on the ground members as well.
I see Shannon and Dan.
Yes, thank you so much. Great reminders, but also some sort of new insights for me, I think, in what you showed us in terms of what's possible. I think what comes up for me is, how does this relate to our context? And just, I think where you kind of ended off there around it's worth the investment. And so a question about overall kind of order of magnitude for the work that you've described, kind of what does it look like in terms of investment? What are the resources? I was really, one of the things I made a star around is the analyst support, for example. That's, I think, something that we find often is having the person who can make sense of the data and interpret the data in a way that's meaningful seems to be where we have gaps in our teams that are passionate about the work. But once there's, especially at the community level, a little bit different maybe at the practice level, but as you start to bring multiple practices together and look at the community level, I think the data becomes a little bit overwhelming. And so, just really curious about the overall kind of resource framework for what you've seen and what that looks like.
Sure. So I think at the analyst level, there was and still is one analyst. There's one analyst to rule them all, if you like, because I don't think it's too resource intensive to have, at a smaller level, people who understand the data enough and can wrangle it. It's too time intensive. People who are interested can, obviously, but what if you decide at the beginning that you have one overarching analyst, but then you have the units of analysis, so that you can see that with each analysis sort of push button, it would separate out into there's the overarching organisation, there's the practice level, and then there's the individual level and the groups were already, those that were grouped together, those individuals for the small group were just sort of automating. And so there wasn't a lot of, once that was agreed upon, there wasn't a lot of effortful analyst work each time. It was really just defining the data elements to be analysed. And I think that it's an organisation that, what's a program now that has significant funding, because it's pretty sophisticated, and there are sort of between 2 and 4 people working as the education team and sifting the evidence and doing implementation stuff. Not full-time, it's not their full-time job. It's usually a family doc who does this part-time, a couple of those to bring that clinical perspective of the evidence sifting, and then 2 people who are sometimes pharmacists actually, but other people who have that more technical approach to the evidence. But it didn't start out that way. So I think it's really important not to think, okay, we have to have all of these resources in order to make this work. At the beginning, when I talked about the pilot, which demonstrated that effectiveness, it was four small groups piloting. The group leaders together did the evidence synthesis. They obviously had an interest in critical appraisal, but it was all voluntary, basically, the evidence synthesis, the development of the cases, and then somebody who worked with that data already, the prescribing data, pulled it for those particular topics. So I think that you start small and say, okay, what's critical in the core, and I think that somebody who can extract the data is key, that analyst, and then you build from there.
And just a quick question before we jump to Dan is, has an economic analysis been completed looking at the investment relative to the return, just given the outcomes you've seen, for example, reduction in prescribing, other things?
Yeah, there's not a published economic analysis, but I can tell you that, so one of the, once this would show the effectiveness, there was a big call, but we assumed that by taking this philosophy that giving people evidence in cases and with the effect that we'd seen, that better practice would be cheap practice and that reduction of variation would be cheaper. And so we entered an agreement with the funding organisation that we thought we could save money for the funder on pharmaceuticals, on lab testing, and in fact, about 10 years later, we also did a project focused around acute medical admissions, and the agreement was that we got to repurpose into the organisation for patient care any savings. And so the education program and the effect of that resulted in $20 million worth of savings. A lot of that went into initiatives around patient care, but you can see it more than funds the program is a drop in the bucket compared to the other things that have been able to be done with that. We also took a much bigger risk in agreeing to cost share the growth in medical admission. So it was the same growth as the laboratory expenditure. It was just going up like every country in the world, acute medical admissions. And we thought that we could keep it stable. We didn't think we would be able to decrease it, but we thought we could stem the rise. And so that was the basis of a project called the Acute Demand Project, which again spawned a range of extended primary care in the community type services.
Right, no, that's great. I've seen good examples of gain sharing being used in other spaces, similar, for example.
It's win-win. It sort of lines up and it engages, I think, a trusting relationship between the funder and the practitioners. Yeah.
Excellent. Thank you for that, Dan.
Thanks so much, Dee, and wonderful to see you again. I've got a few different questions. One of them is just in terms of the data source and kind of accuracy of the data. You spoke to that a little bit, I think, kind of alluded to it, but how critical is that in terms of making sure that people actually feel confident in the data that they're using? Another question is, you mentioned kind of the external versus internal approach to the use of data. I certainly see the external kind of use very consistent with not only data use within this sphere, but it's just such a predominant kind of approach to how we measure and manage things that is a really, really tough one to overcome. It's like to me, if there's any transformation in healthcare, that's probably the key to it, is going from that extrinsic to intrinsic, but it is so counter to the mindset of the majority of people who are in leadership roles that it's just really, really challenging. So just the breadth of that. And the last question is just around Has
I'm going to have to write this down, 3 things I won't remember.
sorry. I can just do them one at a time if that's easier. So the first was just around the data source and the quality and the trustworthiness and how important that is.
Yeah. Nice to see you too again, Dan. Probably we knew each other right almost as we're starting out, or not long after we're starting out these things at Christchurch. So I think the data quality is important, but again, you can, and you know, I think it's important to understand as an organisation too how representative is this data, and you know, you need to do some sort of data quality assessment or trial. You know, do you take, you know, a random sample of you know, going to, you know, you will understand your data much more than I do, and I'm assuming you're alluding to some kind of concerns about data. So you need to go in and do some sort of assessment of your data quality, and there might be different kinds of data that you want to assess the quality of, but it's a bit like proving the effectiveness of the education model. Once you've done it and said, okay, you know, we're sure this is trustworthy for these reasons and it's representative for these reasons, then you can move on. So I do think you're right. I think it is important to know, because yeah, as we know, especially with primary care data, sometimes what you think you're seeing doesn't reflect what's actually happening. And a student many years ago who did a project which is resident in exactly that, where she looked at the assessment of cardiovascular, or the attention that's being paid to cardiovascular risk factors, and a particular source of data was being used by the ministry, and showed that in Christchurch and Canterbury there seemed to be very low rates of attention. Well, we knew that that wasn't the case, and it was because there were various other parts of the EMR that data was located in. And when you looked at all of those areas, she did a really detailed drill down. The fact that actually the quality is very high. So that's just an example of the drill down that you need to do, just to show that overarching the data quality is good, but also whether there are areas that it's more reliable and perhaps less reliable, so that you understand that going forward. Your second question was about how you change from extrinsic to intrinsic, and I think you know, it's hard, but it's doable. And I think that the important thing is to provide an alternative. You know, you can't just say, well, that's not a good way to do things. You have to provide a viable, robust alternative, and something that you show improves quality, and that maybe makes changes, you know, bigger changes. The other thing I think you can do, because I think, you know, in BC, what I read of the kind of burnout and the pressures on doctors in BC, that, you know, this idea of not being good enough, you know, sort of taking that load off is really important. And what that, as we all know, that kind of extrinsic measurement just gives a series of measurements of you're not good enough, you're not good enough, you're not good enough, with no ability to speak back into that. And so what an organisation can do is start to take that data, which is what Pegasus did. We took that kind of data at an organisational level. So we said, okay, we take the organisational responsibility for these things. We will do the things we need to understand that and improve it if it needs improving. But you as an individual don't need to feel bad about that, because with our program, we will address the variation within our organisation. So I think taking the ought responsibility off is a mechanism, and providing a really solid and sort of evidence-based alternative is really important as well, rather than just sort of saying that it's not good enough. Does that answer your question, that piece?
Yeah, it certainly helps. Thanks, Dee. I'll make a quick comment and then the third question, then give it to other people. You had made the comment that doing things well actually is more cost effective. And I just kind of want to underline that, just because I think a lot of people get the sense that if you're going to focus on quality, we can't afford it. Whereas I sort of view it more through the lens that you're describing it, that if you actually do things right, it's better quality and it's less expensive. And I think that's another thing that I think it's challenging for a lot of people to kind of get their heads around. The third question was just, obviously there's effective team-based care within the environment that you were describing. And I think there's a lot of support for team-based care within the primary care environment. But I don't know, did you learn much in using the data? One of the things that I think is a bit of a struggle is in team-based care, is there clarity of roles and responsibilities? How do people work together to make things work well in primary care? And I don't know if there was any learnings in New Zealand about how you structure teams to be effective versus making an assumption that somehow just a team intrinsically is better.
Yeah, I don't know if anyone's cracked that nut, and I would say that it's very context specific. So what might work in one context, funding environment, that kind of thing, will be different in another. I mean, team-based care wasn't in Canterbury, wasn't co-located in the way it is, for example, with family health teams and the team I work at in Ontario, where the pharmacist was on site. That, you know, that those members of the team were on site, so the pharmacists were in the community. So the team was at a community level, and I think shared understanding was the key, really, to having everybody kind of paddling the canoe in the same direction. So, but in the community pharmacists coming on board, it gave a chance to huddle, if you like. There was a reason to get to know each other. Many community pharmacists, like in Canada, didn't even know their local family docs and vice versa. And to also understand what was going on. So, pharmacists, for example, might see prescriptions and be but didn't understand the context or what was going on, say for the PPR prescriptions. And it also was really key in ensuring that when your QI areas for focus were agreed upon, that everybody was on the same page. So it meant that the pharmacists, community nurses, everybody was giving the same message. Or a patient asked of the pharmacist something, the pharmacist would say, "Oh, this is because," that everybody understood. But also in understanding each other's context, I think, part of the QI was about, okay, what's the pharmacist's perspective on this? What's the community nurse perspective on this? And so how does their education differ, and what can we understand from that? And simple things that I learned, like, if I was reducing the dose of something or tapering or stopping something, to just write a zero prescription and send it through the pharmacist, and then they wouldn't think, oh, what's happened to, has Mrs. So-and-so missed a prescription? It saved them a ton of work, and it just hadn't occurred, I feel naive now, but it just hadn't occurred to me just how important that few seconds task could be. So, yeah, we understood. Yeah, I got to understand a lot more about pharmacy and community nursing than I ever would have otherwise. So I don't think you have to have a family health team in the same setting to think about the team in a broader sense. Nor do you need any special something. But I think I've been probably not as specific as you'd like me to be in what works. But I think that opportunity to have a relationship is key. So if you can embed that in the work that you do, and the perspective of, I want to understand what your perspective is on this as we move forward, I think is the other key.
Thank you. So maybe we'll go to Gail. I see your hand up, and then we can pivot to the specific questions that we have that are organized by the section, just to see if we can get some specific input around some of our questions. So Gail, please.
Perfect. Thank you, Dan. Thank you, Dee. I think even your last comment you made may have just answered my question. It's a little bit different. To your point, though, we are always looking at, how can we reduce the manual involvement for clinicians to enter in data. So for instance, if they get a lab result, it's not coded, they have to take that manual intervention to code it in order for our system to be able to pick it up. And so I'm curious, I had two questions, because kind of around that data accuracy and standards, in the Pegasus program, how many different electronic medical records programs were being used in New Zealand?
There was one major one which had pretty much all of the market, and then there were a couple of minor ones. So that was a real strength. It's a strength and a weakness. Sometimes having one EMR kit to the market is not great, and what we noticed was that they weren't responsive to requests for change. That was the downside. But yeah, so it was easier than in the Canadian environment for sure. Although one provider does seem to be trying to gobble up all the minor EMRs in Canada. In terms of data, I think asking family docs who are seeing patients and we know at least an hour of their time, probably more now, that's spent in doing paperwork, asking them to enter data as well, it's not a viable option. And we know that in hospitals that coders are paid to do the coding for hospital admissions. And I think the same philosophy has to be taken. And this is an advocacy piece for primary care, is both getting funding to do that, but not just thinking about manual entry, thinking about systems approaches to that. And I didn't show it today, but one of the things that we did at McMaster, because the data was pretty variable, particularly the disease coding data, and so what we did was we used the Simpson algorithms, which you'll be familiar with. The Simpson algorithms are used to try and describe the epidemiology, for research. But what we did was we took those algorithms, which would be algorithms, if you're on a particular medication, or if you had a particular HbA1c recorded, or or a text word occurs in the diagnosis box, that it's reasonably likely that if you're prescribed insulin, you have diabetes, for example. And we used that to back code, and so we took a tiered approach to that. So there were some things, and we asked for the agreement of the physicians first, because obviously we're putting it back into the medical record. But we asked for permission, and we used tiers. So there's some things that are certain, like, we can be pretty certain that if you're taking insulin, you've got diabetes form. We don't need to ask you about that. Then there's other diagnoses that either are a bit loaded. So mental health diagnosis is very important not to put in the chart if it's not there, because there are all sorts of patient implications. Or it's uncertain. So hypertension is a tricky one, because the drugs are often used for heart failure or ischemic heart disease or things as well. And so what we did then for those uncertain was we gave the patients a list to say, okay, these are the ones we're pretty certain of, and these are the ones that we're less certain of. Can you please just go through and mark when the patients don't have that diagnosis, and then when you get that back to us, we'll bulk code all the rest. So it's a way of sort of using time efficiently without asking people to go in and do individual data entry, and we published a paper on it, which I could send you if you like. But the increase in our disease coding and quality was staggering. That was a really efficient process, and it didn't. We can't burden primary care practitioners with data entry at this point in time. And what we did also was incorporate a feed forward process for data entry, which you can think about. So when somebody I don't know what the billing codes are like in BC, but in Ontario, they're only loosely related to the disease. They cover, it's probably the same. But we sort of coded some key diseases for primary care. And if somebody billed for something that included, say, diabetes or some kind of, or depression, say, when they billed for something that appeared like that, and it wasn't in the disease registry, so we just wrote some code in the bag, a little pop-up would say, would you like to add this to the disease registry? And all you had to do was go yes, boom, and it'd be in. And you just went no. If you went no, it wouldn't bother you again ever. Which is So that again was a really people have to do billing anyway. You're not asking them to do something new. So we just incorporated that with normal workflow and made it one click that they had to do, and we didn't have the pop up appearing multiple times.
Yeah, and I guess I wanted to pick up on one. And I'm sorry, Dan, I will be quick, but just kind of that information back to the system, and whether or not that if you have examples of where your work has influenced how the system may work. And again, the example I have in my head is when we're trying to provide colorectal screening rates back to our clinicians. Again, this is where the data that they get in is a flat PDF file that we can't pick up, and it's not identified as a colorectal screening. So the physician actually has to manually enter it in so that we can pick it up. This is one of the kind of use cases that I feel like, how do we take an evidence-based approach so we can really share that business case with our funding partners? Because I think, right,
it's a problem that we've looked at in Ontario as well. So I think that the first thing is to show your proof of concept, and then say, okay, if you want to focus on your areas, we have to have the tools, the resource that we need to do that, and that resource is good data. And you can structure PDFs. So if you look, for example, at the FDA, a good example is the Canadian versus the FDA drug data sheet. Canadian's unstructured, it's a picture, so it's useless. The FDA is structured so that you can pull out a particular section or category of it. And that would be something that you could, that would be relatively easy to do, doesn't rely on anyone. It's just a system issue that needs a system solution. But I think you have to have some proof of that what you're doing is going to make a change first. And then I think you can make a really good case for that.
Thank you very much.
And thank you again for agreeing to come present to us this morning and for the rich discussion. I'm just going to share my